Excellent. Okay, so welcome everyone to our February installment of Science Under the Stars. We're back into our virtual format. As you can see on the screen now, in March, April, and May, we have planned talks ranging from a bunch of herps to plants and to urban mammals down there in May. But for today, we're with Emily Javan, who is a PhD student with Lauren Meyers and who's also a member of the UT COVID-19 Modeling Consortium. So she is uniquely and definitely qualified to give us our COVID update over the past couple months. And her research, or she's definitely interested in how diseases spread between animal and human populations, which seems extremely relevant, as well as how vaccination and wildlife management can actually prevent these epidemics. So Emily, I won't take up any more of your time. Please update us on all things COVID, and thank you very much for coming on our program this evening.
All right, I think I am unmuted now, hopefully.
You're good to go.
All right, perfect. Yes, and get your faces out of the way. Okay, great. So we're starting good. 5 after the hour. So probably about a 40-minute talk. And so we're going to discuss COVID-19 infections in Austin, Texas. And so what I mean by that is really the 5 counties that make up the Austin, Round Rock, San Marcos metropolitan area. And so there's 85 zip codes within that. But you can, if you know where Austin is, that's pretty much what we're talking about is the Austin area. There we go. Now I can click. Okay. So here's a little roadmap of what we're going to discuss. I'll give you a brief intro on me and the COVID-19 Modeling Consortium. We'll discuss a bit about how COVID disease progression works within people, how we're going to estimate the infections in Austin, the results we got, and look at this thing called the Social Vulnerability Index. And so for some of our younger people or anybody who just wants to like play along, we have some secret helpful habits. They're little pictures that are hidden in the slides. So here's one example of cough and sneeze into your elbow, please. So there'll be other ones. So if you have a pen and paper and you want to record those, you can give us your answers at the end before I reveal them all. There we go. Okay, so me and the team. So the team is actually a pretty big collection of people, as you can imagine, with a global pandemic. So like we already said, I am a second-year PhD student here at UT Austin. And there's me. And I'm actually part of the Meyers lab. And so Dr. Lauren Ancel Meyers is one of my advisors. And within my lab, just here at UT, of other PhD students and postdoctoral students, we're all in this lab together. And then within our consortium, we have other leaders. So one of my other advisors, Dr. Spencer Fox, and someone who works and helps manage us, Dr. Becky Keister, they are in charge of the consortium. And like within the consortium, we have mathematicians, statisticians, geospatial analysts, doctors, as the word doctor. All these other doctors are not medical doctors. They have doctorates from different disciplines. But here are 2 doctors like you might go see at Dell Medical Center. We have people from the Texas Advanced Computing Center, which is our big Texas cluster of computers. And so it's where we run a lot of our models. And all those other people were just within our UT community and even outside of the UT community with the Santa Fe Institute and beyond. We have a lot of people. And this is just a handful of the people that I actually know and see and, talk to on Zoom. But there's so many people who work with this consortium. It's like a really great team. So as you can imagine, from a really big, diverse team, we actually model a lot of stuff. So here's just 2 quick examples of kinds of modeling we do. So on our projections website, this is for the Austin Round Rock MSA, that metropolitan statistical area. And this is COVID-19 hospitalizations. And so here in these little gray spaghettis, we're estimating how we think the hospitalizations are going to go. So some of them, these little spaghettis, are shooting up, and just through like random chance in our model, this hospitalizations ticked up because a lot of people got sick and needed to go to the hospital. But on average, it's trending down. We think hospitalizations are starting to decrease, which means we think COVID-19 spread in our like vulnerable communities are decreasing. And over here, this is something else that's not really a projection, but a tool that you could use. And this is COVID-19 cases arriving at school. So down here, you would toggle your pod size. And let's say my pod has 50 people in it, 50 people came to school. And for all the counties within the US, we're estimating how many people do we think would show up to your pod infected with COVID based on the disease dynamics within that area. And so that was just kind of a brief, like, what do we do? But like, where are these dynamics coming from? Where does this disease progression come from? Well, it comes from a model, which when somebody gets exposed, if they then get infected, they will have viral particles that get into their cells and start to replicate. And as they're replicating more and more and more, eventually you get up to a level, which is this pink bar coming up, where you have enough viral particles in your body that you become infectious. So when you go out and about and start breathing on other people, right, during this pink arrow window, you are infectious. And so this is your viral load. So as your viral load is increasing, maybe it gets to a certain point where your body starts really reacting poorly to having all of its cells exploded by this virus. That's just a little machine replicating itself constantly. And then eventually your body starts figuring it out if you have a nice, healthy immune system, and then brings you back down. And we would say you are recovered when your viral load is low enough, like it doesn't have to be 0, but at least low enough that you're no longer infectious to other people and your symptoms have subsided. But COVID is super weird. So here's where this header came from. Disease progression isn't the same for everyone. So in some of our patients, right, they are exposed, we get that curve, and they get their symptoms, and then they recover in like the normal pattern we would expect. But for some people, even though they may no longer be infectious, they're still having symptoms. So they could be long haulers where they don't feel well, but they aren't necessarily going to go out and get somebody else sick because they don't have that load, that high viral load anymore. And some people still go through the exact same disease progression, but instead, they don't ever get symptoms. So it's really hard for them to know, like, am I not feeling good? Well, then I won't go to the store. Well, if I feel fine, then maybe I will go to the store. So this is a tricky disease where even, as you could kind of see here, this person is infectious before their symptoms even started. So even if you are feeling okay going out to the store, right, you could still be infectious before the symptoms come, or potentially your symptoms never come. So where do we actually figure out who's infectious and who has been infected, right? We have these rapid tests. And so rapid tests will say that you're positive when you have a much higher viral load. So it's more likely that when you are infectious and this rapid test comes back positive, then you are actually currently infectious. Not necessarily you have a positive PCR test down here, but your infectiousness has already passed. You were infectious, and now your body is slowly recovering. And so it can be important then to not just get like one test, but if somebody gets a test here and then they get one another day, then it might be positive. So multiple tests. And if we have multiple tests here, and then they keep decreasing, that's kind of a good indicator that like, oh, you were infectious and now you're getting better. And you're probably okay to go back out and about if you feel okay. Okay, so that was kind of just all I was going to say to get us on the same page about models and all these other things. But lucky for us in this talk, we don't really need such complicated models to do what we're going to do. It's really just one calculation, and then that's what we're going to discuss. So the question I want you guys to really think about is, where are most of the COVID-19 infections? And this is not a question of where are the most currently infectious people, right? You would need some other kind of modeling to do that. But in terms of infected, previous now or in the past, where are most of those people? And so here, this zip code with the darkest purple and a yellow outline is actually new cases in Austin. So this map is pretty cool. It's pretty useful in terms of like understanding which zip code has the most new cases. But in order to get the count of we have a new case, you need to be testing. And you need to be testing enough that you're catching people when they actually are infectious enough or have enough viral load that we would say they are positive and count that as a case. So this map kind of assumes here that everybody is getting tested equally across the region. So while from the data we have, this is where the most new cases are, but there's some caveats to that in terms of just understanding what is a new case. Is that actually an infectious person? So good things to keep in mind. But we're not thinking about infectious, infected. So who is or was infected? And so that can be really important for understanding our testing and tracing of contacts, because if we estimate we've had a lot of infected people in an area, but our testing data really doesn't reflect that well at all, then maybe we need to put more testing sites there, help it be more accessible to those kinds of people who live there, who are getting sick, but maybe they don't own a car, and they don't live downtown, so they can't just walk up to something. So it's really important to think about an equitable way to make sure everybody has the same opportunity to get tested and be a good citizen and prevent spreading coronavirus. It can also be really important for our vaccine rollout plan and understanding why those infections are concentrated in those places. So once we have the map, we can kind of dig into, why does the map look like this? So the data that we actually use to do this is from about 17 hospitals within the MSA. And as of January 11th, so today's February 11th, so 1 month ago is when we stopped taking data to make these pictures, there was 6,444 hospitalized patients who had a positive COVID test when they went to the hospital. And when they were there, the doctors, nurses, they recorded their age, their zip code of residence. They record when they came in, when they left, did they need to go to the ICU, did they need a ventilator? And for some of them, it says this person is retired, they live in a nursing home, they are a construction worker, things like that, to kind of help you understand where they could have potentially been infected. And I highlight these two, age and zip code of residence, because those are really the two pieces of information we're going to use to calculate the total number of infected people in Austin. And so here we have broken down by age group, these over 6,000 patients. This is the total hospitalizations. And so we can kind of see as age increases, we're increasing in the number of people there. So the 50 to 59-year-olds and our 60 to 69-year-olds each have about over 1,500 people who have gone to the hospital, right? And so there it kind of looks like, well, a lot more people in those two age groups have been hospitalized. But then you ask, well, how many people in those age groups actually live within our area? Because within this big area, there's about 2.2 million people, right? So is there a really large number of this older population? Is that why we just see more of them at the hospital? So when we normalize per 100,000 residents, we see, no, actually, the people who are going to the hospital the most proportional to how many of those people there are really our oldest age groups. And that kind of makes sense because typically for our oldest age groups, their immune systems are not the strongest and the best at preventing disease and bouncing back really quickly. They usually need some hospital assistance. And when you are that age, you typically could live in a assisted living facility or somewhere else where you're in much closer contact with other people. So if one nurse came in and she was sick and then got that person sick and another and another and another, right? Now we've got a lot more 80-year-olds who have been infected than if they were all living individually by themselves. Okay, so once we have that data, this guy here is broken down how many people per age group went to the hospital. We use some kind of rate to back out, well, what is the expected proportion of each age group to go to the hospital? So we'll estimate how many people were infected from a hospitalization rate for each age group. So with this rate, it's written as a percent. So for our 0 to 9-year-olds, so our youngest age group, we estimate that only 0.1% will end up needing to go to the hospital. So this is of infected people. What percent actually had such a bad infection that they then required hospital care? And so naturally this increases as people get older. And what does this really look like? So on average, 1 out of every 1,000 infected people will be hospitalized from COVID. So that's why we have one little red dot here. That's our one poor infected person who ended up needing to go to the hospital out of this 10 by 10 grid, which is 100 times 10, so 1,000. So we have 1,000 little squares here in who all were infected, this 999 people who never had to go to the hospital, but this person did. Those people certainly could have been tested and been popped up as new cases, especially for our younger age groups who are still in school, playing sports, doing things that they may require regular testing. So this is just based on who went to the hospital. And here's the exact same thing, but for our oldest age group, where now 22% of our 80 plus adults will need to go to the hospital. And so that's the same, 10 plus 10 plus 2. In each of these 10 grids, 220 out of every 1,000 infected 80-year-olds, 80 and older, will need to go to the hospital. And so we can just pause for a second and think, well, what would change these numbers, right? Because I've just kind of thrown them out here, and somebody else from this paper estimated these numbers, but certainly their estimates come from data, right? And other hospitalized patients and testing, right? So what do you think within each age group would actually change what proportion were infected and needed to go to the hospital? Okay, so hopefully this schematic, these little pictures, make it easier to see. So which of these two groups has a higher risk for hospitalization? Do we think it's our healthy group that's very active, they've been taking good care of their lungs, they eat a healthy diet? Or do we think it is our sloths who like to lay around and watch YouTube all day, eating ice cream, maybe making other bad choices? So of these two groups, over the course of their life, if they weren't making healthy choices, who is going to need to be hospitalized once they're infected? And I'm sure all the very smart people figured that out, right? It's our unhealthy group is probably more likely to go to the hospital once they've been infected. And so hospitalization rates will be higher in groups with higher at-risk populations, and that's at risk of hospitalization. And so if we have lower hospitalization rates for these high-risk groups, then we would actually overestimate what percent they were infected. So if instead of being 0.1% of our 0 to 9-year-olds, it was 1%, right? That's an order of magnitude. That's 10 times overestimate. So that's why it's actually really important that when we present these numbers, we're presenting them with a lower and an upper bound, because there's some range of possibility, right? 0.1 is what we think is the best estimate. It's the average. It's in the middle. We think this is true for most people. But if in an area, those 0 to 9-year-olds have a lot of diabetes, childhood cancer, other things, asthma, right? Then they would be more likely to go to the hospital than a much healthier population. So a low rate of hospitalization is on that side. It's our lower bound. And our upper bound is for a high rate of hospitalization. Okay, and so this is results. That was all the methods. So we have percent infected by age group. So this is using those rates and backing it out for everybody in the MSA. We have the percent here. So we estimate the percent of each age group that has already had COVID. They could have currently had COVID, but this hospitalization data stopped at January 11th. So likely those people have recovered. So it's probably all people who in the past had COVID. And so we can see for our youngest age groups, we actually have the highest proportion. 10 to 19-year-olds, roughly 30%, we think on average have already had COVID. But since they're young, right, and they're less likely to go to the hospital anyways, we have a much bigger range here of uncertainty. So below 20 all the way to almost 50, right? And then as we go down, it kind of makes this wiggly worm. We're going down and down and down, and then his tail kind of goes up. And why is his tail going up? Well, we can only hypothesize about that, but it could be, like we were thinking earlier, our 80 and above tend to be in closer living quarters, right? Because they're in assisted care facilities, things like that. So very early on in the pandemic, this data ranges from March 3rd all the way to January 11th. So there could just be a lot of elderly people who got infected early on, and that's why it shows up a lot of hospitalizations. So higher percent infected. And so that's all age group. Now looking at some more results where we break it up by zip code. And so our highest, these deepest, darkest red colors, that's our zip codes with the highest proportion of infections. So this white star actually has the highest estimated percent of 41%. And it's lowest over here in Cedar Park with about only 4%. So when we look at those numbers here, it's probably a little bit easier to see 41%, 41 out of 100 versus 4 out of 100. That's about 10 times more, right, in this zip code have been infected than in that zip code. And so when we kind of look at this, then we start to think about, well, why would that be? And so one thing that the CDC calculates that might be helpful for us to understand why is this social vulnerability index. And so what are you vulnerable to? What is a social vulnerability, right? So it's vulnerability to excess suffering when faced with a disaster. And so there, a disaster can be like the pandemic, like we're thinking of, right? So crowding, poverty, over 65, those would be pretty relevant for that kind of disaster, right? But a tornado, a hurricane, right? No vehicle, that could be pretty important as well, because then we need to put you on a bus and ship you somewhere else to be safe and out of harm's way, and then bring you back. So a lot of different things here, these 4 different categories that we think if you are rank high in something like this, you're probably more vulnerable. And so this score goes from 0 to 1, and the CDC calculates it annually. Perfect. Okay, so here is this SVI broken up by all the zip codes within our MSA. And so it actually ranged from 0.04, which is very low vulnerability. It means you have a good chance of when some kind of weird, random natural disaster thing occurs, you can bounce back from that pretty quickly. You won't suffer too much when that happens. Whereas 0.81 is pretty high. It's not the highest, which is 1, but that's pretty high. So if something bad happens, you lose your job, something else, maybe you don't have savings to live off of, right? Things that come up are more likely to affect you more. And we see that our highest vulnerability in the MSA is actually east of the I-35 and the 183. So over here. So if you have been in the area a while, maybe you've heard this already referred to as the Eastern Crescent. And that is actually historically Austin's most vulnerable populations in terms of where like low income people are concentrated. So when we look at this and we think about the map we just saw in terms of where are the most cumulative infections, they kind of have the same pattern. And I just wanted to point out this map while we're thinking of social vulnerability. Maybe you're thinking, well, like having a low income and not having a car isn't really a health risk. That has nothing to do with your physical health. But it's important to understand that, within the community, this map is from 2011. And so these tiny little yellow squares are where are not full service grocery stores, or where are, non-full service grocery stores. And the bigger pink salmon squares are where are the full service grocery stores. And so a full service grocery store, you can get like your fresh produce, your vegetables, things like that help fuel your body and make you more healthy. So if you were living over here in Austin a decade ago without a car, for you to go get fresh produce, go get clean food, you're probably going to have to take hours-long bus ride to the store, get back on the bus with all your fresh groceries for the next week or 2 weeks, and then go home. And if you work constantly, right, that might be really cumbersome and inconvenient. So you might be thinking like, well, how do those things really relate to not being healthy enough that when you get sick, you respond well enough to just bounce back and not need a hospital visit? But sometimes your community just isn't structured in a way for you to naturally make healthy choices. So just keep that in mind, because you might be thinking of yourself in your community, but think of yourself in your community with no car and little money, and then the pandemic starts, right? It's going to be really hard for you to manage. And so this is actually just relating those 2 maps we just saw. So here's the social vulnerability down here, and then cumulative infections are going up. So on average, as your social vulnerability increases, we're actually seeing that within that zip code, there's an increase in the percent who have already been infected. And so if we start here at 0.1, we move over to the 0.2 and go up, right? That's about a 3.5% increase. So for every 0.1 you move up in social vulnerability, you're actually getting a higher proportion of your community that's already had COVID. So that's what we estimated anyways. So if you believe all those numbers that we use to back out these calculations, then that's what's feeding into this. So what is left to do? So currently we're actually working on updating those maps. Not the SVI map, that one's made by the CDC, so that's good. He gets updated annually. There might be a new one up for the new year soonish, but that part's good. The map we're updating is that hospitalization and those hospitalization rates. Because if we can actually measure comorbidities such as like diabetes, asthma, pregnancy, things like that, then maybe we'll get even better estimates that like truly reflect what the risk structure is like of that population within the zip code. So we're working on that right now, because right now we've assumed every single zip code has the same kind of risk structure, and that's where we're at. And then beyond just kind of updating these maps, we need to start thinking about our equitable rollout of vaccines. So even after we vaccinated our older patients, our teachers, people like that, eventually it's going to have to come to everybody. But if the site to go get that vaccine is going to be hours bus ride away from you, and you have to take off work, maybe it's just really inconvenient and unlikely that you're going to be able to do that. So in order to make this rollout as equitable as possible, we really need to think about where people are and what resources they have. And it's the same is true for testing sites. So while this testing is awesome, this person drove up, these two people are protected, everybody is isolated from the people behind them in their car. If you don't have a car, you can't go get in this queue of cars and wait all day to get a test, right? And you certainly can't go get testing in multiple days to go figure out whether or not we're growing on that infectiousness curve or decreasing, right? So it's important to make sure there are easy access to tests and vaccines, even for people in our rural communities who aren't just concentrated with good walking spots within the city. And last but not least is to be very kind to yourself and to others. It's a very stressful time, I'm sure, for everyone in a lot of different ways. And we're like a year into it. So I think it's really important that while we're thinking about all these other things, we're also thinking about how we can be better to our neighbors and show more love and affection, even at a safe distance. So we want to physically distance, but not necessarily socially distance and isolate ourselves from our community. And I just wanted to say thank you to my advisors and my lab mates, who you kind of saw pictured earlier. And on this project itself, we have my 2 advisors, and then a bunch of other awesome people who really help think through these things and how do we improve these estimates and make them a lot better. And then if you're interested more in just the consortium itself, to go check out those projections, check out some tools we've made, tons of awesome things, go to this website. This is the webpage of just the Meyers Lab. So if you just want lab things, like maybe you're a prospective PhD student and you want to check out the lab, go there. We have a Twitter. So if you're interested just in the things we're doing in real time and seeing reports and stuff come out, go there. And the full report is here at this little DOI. And that will have a lot more pictures and math and other things, like the more complicated way in which we calculate these numbers. But I gave you the kind of easiest, simplest version of how you could calculate these numbers. And the next slide I know is all the answers to the secret photos. So I hope everybody has thought. You could maybe put in chat now how many you counted if you were playing along. Okay, here's all of our not so secret habits. Yeah. I'm sorry, I thought I heard something.
No, that was me. Thank you. Thank you very much, Emily. That was awesome. And I know you're not gonna be able to hear it, but I'll give you a nice round of applause. That was awesome. So we will open it for questions. There's a few in the chat, so I can start with some of the earlier ones. So if and when you are modeling this type of or diseases, how would you model the capacity for a virus to mutate? So would that be incorporated in a model, or is something different?
There certainly are models in which you could, actively have some mutation rate that has like X consequence, right? Ours do not. We try to get the best parameters for a variant, right? And then just model that variant, right? So especially as new variants come out, there'll be different models. Well, if we have this one going and this one going, what's the likelihood that a certain proportion of people get infected? But definitely as you build up your model, you're making more and more assumptions about what the reality of the situation is. So it actually creates a lot more uncertainty. And so at a certain point, if you've put in too many parameters that you're not very confident in, you can't be very confident in your results. So if you can create the dynamics of one disease spreading that you think encompasses much better all the other variants going out and about, then that's a good move.
Awesome. Okay, so your model loses liability if you introduce too much to it, right?
Yes, it does.
Cool. Awesome. And so you were talking about, I think it was around the hospitalization rates. That wasn't your model, correct?
I'm gonna go back in time. Yes.
Right
okay.
there. So
yeah. So these guys, no, we did not make these numbers. This comes from doing a lot of testing, right? And then having people end up needing to be hospitalized, right? So you're kind of estimating this proportion of people who you knew were infected and what proportion in that age group went to that hospital.
Okay. And just off the top of your head, do you know if those models incorporate ethnicity?
Do they incorporate ethnicity? No.
Okay, so it's just general.
But they do incorporate things like asthma, diabetes, all these other kinds of things. So you have an estimated like proportion of this age group. So they're much more specifically like true comorbidities, not just these correlations of you have more melanin in your skin. And then we've also noticed that more people like this go to the hospital. So while you could like make those assumptions, the act of having more melanin in your skin is not a comorbidity, right? That doesn't make you go to the hospital. It's something else about your life history that is causing these increase in hospitalizations. So capturing that is way better because we can capture it for everybody who is in that risk group.
Okay, so it might not be super informative to report.
I mean, it's a good proxy. It's a
Right.
good way to get like an estimate of, well, what kind of people are we seeing the most? And then, look behind that and be like, well, how do we make access to healthy food more equitable? How do we make it so that, you can live a better lifestyle and prevent needing hospitalization?
Awesome. Somebody else asked, given the data you've presented today, do you think this data would help open schools?
Well, I think it would help open schools in terms of like a school district in this area has already had, some proportion of their children infected. Therefore, the chance that more kids get infected would be low, something like that.
Potentially.
I
Catherine,
mean, I think it's really a school by school thing because we're estimating it for like children within the entire MSA. And, it's based on your zip code of residence. So just because you live in this zip code doesn't necessarily mean you go to school in that zip code, right? So schools school boundaries are like really weird and they intersect a lot of things. So I would be hesitant to just say, look at all these children that have gone to the hospital already. That must mean a huge proportion have been infected. So let's just let it rip. That's probably not the advice I would counsel.
That's fair. So around January 11th is when you said you stopped collecting data for some of this information. Why was that date the cutoff?
That date was just a good date because when we were doing all of this, it was really close to the time in which we were making this report. So this report has been out for a little bit and we had kind of updated things like 1 week out. So it was just a Monday. And people who might be looking at the data from time to time, you might notice that there's usually a drop in like reporting of things over the weekend. People have lives and not all nurses are, cranking out, putting in things. So Mondays are typically a good day. So that's why I chose Monday.
Okay, cool. And so what percentage of people would need to be immune before you started incorporating immunity into your model?
Well, let's go back. Okay. Here, right, these symptoms are kind of dying down as the infectiousness is going down. I hope you can see my mouse, which means we're making some assumption that like your innate immunity is going like this, right? That's kind of reaching this plateau, which is protecting you. But, immunity, as you have it, can also wane, because if the threat isn't so constant, your body doesn't feel the need to make all this excess stuff to protect you from a threat that you're not really receiving anymore. So in models where we actually are doing these dynamics, there are some assumptions about, was this person just recovered and they can't be infected again? Or after some period of time, does their immunity start to wane? And you can make estimates about that based on people being reinfected. And like the data on reinfection is pretty sparse right now. So certainly the longer the pandemic goes and the more data we get, the easier it is to build those kinds of models with confidence. But in terms of this, like just using the hospitalizations to back stuff out, that really isn't dependent on the recovery of people. That's really dependent on what is that rate at which hospitalized people or infected people go to the hospital. I hope that was clear.
No, that was
Okay.
that was very insightful to that. So there are no more questions immediately available in the chat, but except for that one. So Christina, one of ours, any ideas for making vaccines more equitable?
Yeah, I think in terms of really trying to be empathetic and understanding who we're going to vaccinate and like what their life looks like now, because people are probably working a lot. And if they don't have a car, we can't just say, if you're in the area, HEB, right? I like going to HEB. There's one around the corner from my house. I could walk there, right? Even if I didn't have a car, I could walk to my HEB and like go get a vaccine and do my grocery shopping. But if full grocery stores don't exist in that area, or hospitals where we might need to like keep this kind of storage, right? It's important to think about, well, can we send out like a vaccination truck? Can we make it really aware for that community that like on this day of the week at this time that isn't just normal work hours, we'll come through. If you missed that one, let us know. We'll come back, try to really have good data on who we vaccinated, where they were, how easy was it for them to get a vaccine? So things like that. Because if it's just a like first come, first serve at like one location, the people with the most resources to take off work, get in their car and drive there, we'll get them first. So just need to think about distributing even to the people who can't drop everything and make getting a vaccination their first and only priority.
That seems pretty fair. Ooh, does Texas have a state vaccine registry?
State vaccine registry, like a registry of all the people who have ever gotten what vaccine?
I assume that's the intent, and that sounds very un-Texas, but maybe I'm wrong.
Emily, I think it sounds a bit less than like, not un-Texas, but just probably not even like an American way in which we structure our data. Like in terms of like the UK, right? They've got like their UK biobank. And since it is like a nationally run service, the data like is the data. It all goes into this pool and is an open resource, with anonymized people, and you can figure these things out. Whereas we much more have it that like the hospital itself owns your data. And we don't really release it as readily to patients. And we certainly don't pool it and keep it like as a nation, So while there could be some pretty good estimates, right? There's papers, all kinds of things of like, oh, vaccine hesitancy is increasing, vaccination rates are declining. Certainly as a nation, we could put more energy into creating a really good database that is reliable and helps us know. But at least for young people, right, there's probably requirements of like, you need these vaccines to go to this school. So the school itself may also know what proportion of its students are vaccinated, and then you could kind of like pool that for Texas. But in terms of one really central, ready to go location, I'm not sure if that exists, but it'd be cool.
I feel like it would be helpful. I have a question if we don't have any immediate ones. So I've seen this disease compared to a lot of other diseases. And one thing that caught my eye was some discrepancy on the basic reproductive number of COVID.
Okay.
Do you happen to know what a close estimate of that would be? And could you elaborate on what a basic reproductive number of a disease is?
Yeah, definitely. Let's just think about like, what does that term mean? So the reproduction number is an estimate for every one infectious person. On average, how many people am I likely to go out and infect in a fully susceptible population, right? And so that can actually vary quite a bit based on, well, where do you live? What do you do? Are you in a lot of school sports, or do you work with a lot of people? Do you live in a really crowded house, right? So that's why it's an average. And so for something like measles, that average is super high. So, but that average would change whether or not you're in like a super dense city or you're like really out in a rural area. So that's why you see a lot of differences. And maybe you've even seen the like time dependent reproductive number. That's kind of like, oh, if it's above 1, we think we're growing. If it's below 1, we're decreasing. At 1, stable. So that's an estimate through time of, on average, how many new people are getting infected from one person.
Cool. Do you know of the average for off the top of your head with COVID by chance?
I feel like it ranges anywhere from like 2 to 4, and like early on, there were things like even higher. And so, as we get new variants, right? If we're talking about like Wuhan 1, the very first strain that swept through the globe, I think that has a lower one. And some of the newer ones that we've seen are even more easily spread, right? So even like within this coronavirus family, there could be a huge range just about variants alone.
Okay, cool.
So,
thank you.
Mm-hmm.
Are there any other outstanding questions? Feel free to type them in. I don't know if anybody can unmute themselves, but I think I trust everybody here not to go off a deep end. All right. Okay. Well, Emily, thank you Okay, yeah. We are recording, so you will be held accountable for what you do. Emily, thank you very much for coming out and giving us an update on the COVID-19 situation in Austin. Thank you again for your time. Thank you, everybody else, for your enthusiasm and your patience. And we'll see y'all in March for a herpetology talk. Thank you, Emily.
Thank you so much, you guys. I
Thanks,
appreciate
Emily.
family and friends coming and checking it out. Now you know what I do.